Hello, I'm Darren McGuire, and I'm here today with Dr. Sanjay Kaul and Dr. Paul Thompson, and we're going to be discussing the recent FDA labeling changes for statins, specifically focusing on the diabetes signal for diabetes incidence, but also talking a little bit about the cognition signal. So let's just dive right in, and I'll just ask straight up, Sanjay, do you think the signal for diabetes is real?
Tough to say. The data tell us that compared to placebo, statins increase the risk of incident diabetes by about 9%. And compared to moderate intensity statins, high intensity statin dose increases the risk by about 12%. And these are derived from meta-analyses of 13 studies, the placebo-controlled studies, and 5 high intensity versus moderate intensity statin trials. And so, in my opinion, the quality and the quantity of the data are not sufficient to adjudicate the diabetogenic risk associated with statins.
Okay. Paul, you have an opinion?
I think the signal's real. So I think the signal's real because it comes out of a meta-analysis. Granted, it wasn't a pre-specified endpoint and all that sort of stuff, but I think what we need to keep in mind is that even though the endpoint looks real, the absolute risk is quite small and the benefits of statins remain.
Yeah, and I think supporting the reality of the signal, I think, is, there are some graded associations, as one may predict. The older have higher risk than the younger. Interestingly, probably because of competing risk, the lower weight participants actually had a higher incremental risk or relative risk than the obese. And I think in the obese state, you have metabolic syndrome, underlying insulin resistance, so the competing risk of the underlying substrate, I think, makes that real. Let's pretend, at least for now, that it is real. Is it important? And by that I mean, is it important in everyday clinical decision making given the data that we have presently?
You want to take it, Jim?
Yeah, I would say unequivocally, I would not make a decision on the basis that a patient was going to develop diabetes or had the small possibility of developing diabetes. Now, if you look at the Jupiter trial, which may have had a higher absolute risk because a lot of those people had metabolic syndrome. About 40% of both groups, placebo and the treatment group, had metabolic syndrome. If you look at the absolute risk, it went from 2.3 to, I think it was 2.8 of physician-diagnosed diabetes. That means that there were 5 cases in 1,000, 5 cases in 1,000. So even though I'm very interested in the side effects of statins, I always say that I came not to bury statins, but to praise them, because their overall benefit, when you look at their benefit in reducing the risk of vascular disease, is so great. And so if you take and look at the benefit of statins in so many conditions, in hypertension, in diabetes, the benefits clearly outweigh the risk.
Yeah, and to add on to that, we're talking about a variance of a biologic marker, that is the glucose, fasting glucose or hemoglobin A1C or whatever we're talking about. Not to say that that's unimportant. Diabetes, as you get glucose or A1C exceeding the thresholds, there are clear incremental risk associated, at least in spontaneously developing. Whether that exists in drug-induced, we don't even know that. But let's say that all plays out. We're still talking about a diagnosis based on an arbitrary threshold of risk for micro and macrovascular disease. Contrasted that on the backdrop of evidence basis for major adverse cardiovascular event reduction. In the Jupiter trial, it was one absolute risk reduction for MACE was 1%. Now, arguably, it was revascularization primarily driving that, but there's a signal in the right direction for myocardial infarction and for mortality as well. And so we're talking about the diagnosis of a risk condition versus prevention of major adverse cardiovascular events. And so I think even if the signal is real, the absolute risk reduction makes it still a favorable, even if diabetes was a catastrophic clinical event. And since it's not even an event, it's simply a risk escalation, then I agree. I think it's probably real. I think there are going to be some people that are going to achieve the diagnostic threshold for diabetes because of the statin, but I think it's worth the benefit, both for the individual, and we don't know that's speculative, but also for population. So, Sanjay, what do you think?
Well, I think the key question here is, are the diabetogenic effects of statins, if they're real, are they coupled or uncoupled from the cardioprotective effects? So the data from Jupiter are insightful in this regard. In the Jupiter trial, 80% of those that developed incident diabetes had a fasting blood sugar greater than 100
at baseline. So they were already in an at-risk
right.
category before.
And this category of patients derived a similar overall treatment benefit compared to the overall trial cohort.
Right.
So that leads me to believe that perhaps the patients who are developing diabetes also are the patients who are deriving benefit. So if they are coupled, then I don't have a problem in continuing to prescribe statins because the treatment benefits clearly outweigh the harms. Mm-hmm. But if they are uncoupled, then there is a problem. Mm-hmm. And the types of analyses that are necessary to address this is to look at how many of patients developed cardiovascular events alone, how many of them developed cardiovascular events or diabetes alone combined, or how many of them developed diabetes alone. And then see the differences between placebo or statin or moderate dose versus a high dose intensity statin. That type of analysis requires patient-level data meta-analysis. That, as far as I know, has not been done.
Right, and how reassuring is it to you that even in manifest diabetic populations, specifically the diabetic subset of the heart protection study, the CARDS trial, the ASCOT LLA trial, all of them showing such benefit with statins in a manifest diabetic population that it changed the guidelines and required, now we include diabetes as an indication in and of itself. Right. That's awfully reassuring to me that probably the former scenario is the case and not the latter. That is, that the benefit of the drugs, the point estimates of benefit in diabetes is larger than we see in the non-diabetic population. Goes with the age-old paradigm. Higher risk patients benefit greater from evidence or effective therapies, and so
that leads me to argue that in high risk and intermediate risk patients, the benefits of the statins outweigh the risks.
Yes. Yeah. Same argument I'm making.
In low risk patient population, one can debate.
Right.
But if they're coupled to the cardioprotective effects, then I would say that it's justified to give it in high-risk and intermediate-risk patients.
Okay, another level of conversation to tap Dr. Thompson's expertise. Are there muscle-level mechanistic explanations for potential statin-induced insulin resistance?
So it has been an interest since really the early 1990s, and I could give you a list of about 8 or 9 possible causes of muscle-related things, but I think it may be related to what we're talking about today. It may be related to mitochondrial changes, because if you look at the areas where statins may have problems, it may be in the muscle, it may be in the brain. Both of them are high sort of mitochondrial and energy-requiring organs. So I wouldn't be surprised, as you pointed out so well to me when we were talking earlier, that the muscle is the major disposal source for glucose. If you got good muscle consumption of glucose, you don't get diabetes. So if there is some sort of mild effect on mitochondrial function, you could produce some of these muscle complaints, very rare central nervous system complaints, but also increase the risk of diabetes. So for me, it makes sort of an associated rationale. Mm. Now, as we talked among ourselves, we can make up explanations for lots of things, and we're smart guys. We can imagine lots of causes. But it may be a mitochondrial.
Well, that may be a source of a new grant for you. You probably have the world's greatest referral basis of these aching statin-treated patients. So maybe patients who ache versus those who don't. Maybe we could see a glucose disposal difference or OGTT difference or something else to give some biologic underpinning.
I hope this is going to doctors and not to patients because I have enough calls already.
Okay. Darren, I think it's important to keep in mind that the FDA's labeling update does not apply to pravastatin. It applies to all the statin except pravastatin. And the reason why it doesn't apply to pravastatin is because the WASCOP study, the primary prevention study with pravastatin, actually showed the opposite
We've
effect.
come full circle, haven't we?
Yeah. It reduces the risk of incident diabetes in that study. And once we made that observation, which was never pre-specified, it was a post hoc analysis, then we started generating speculated mechanisms for it. Well, pravastatin reduces triglycerides. Triglyceride has an impact on insulin sensitivity and resistance. Maybe that's the mechanism. Or pravastatin has an anti-inflammatory effect. It reduces interleukins and TNF-alpha, therefore, and diabetes is a pro-inflammatory disease. Or pravastatin improves endothelial function, and endothelial function is somehow correlated with that. The point I'm trying to make here is that we should stay away from speculating here, even though whether it might be a biologically plausible mechanism. I think I'm not convinced if the signal is real. I'll tell you why. It's quite possible that this may be subject to a selection bias, okay? The way the patients actually end up getting reported to have developed diabetes on statins is if they had a side effect. If you develop a side effect, you're more likely to develop a side effect on a statin. That increases the chance of an interaction with your physician, which then orders a blood test and finds out, oh, your blood sugar increased from 115 to 126. You're diabetic. So there's a selection bias. There's another possibility of what moral hazard. People have brought this up. If you're already on a statin, you don't worry about a lifestyle intervention anymore, and that could make increase your weight and make you diabetogenic.
But these are randomized and blinded trials. When it comes from the blinded trial data,
yeah, but they are not still balanced in these covariates. Meta-analyses are essentially observational data sets. These are post hoc analyses. The third point I wanted to make is the competing risk, or a survival bias. You're living longer, and you're more likely to develop diabetes because you're living longer. That's why I was very hesitant to conclude that the signal is real, because we really haven't excluded the possibilities of these confounders.
So Darren, I want to go back to something that Sanjay said, because I think it's very insightful, and that is he pointed out that those people that may get diabetes may also be the ones that benefit the most. And I think that, I don't know about the two of you, but I was sensitized to this problem primarily out of the Jupiter trial. That's when I first started to think about it, even before the meta-analysis came along. And as I said earlier, the Jupiter trial was selected on the basis of a CRP. So those folks had a high rate of metabolic syndrome. Some of us think CRP, metabolic syndrome are associated with each other. But the fact that it came out of that trial gives you the idea that it's maybe these people with metabolic syndrome who are more likely to be pushed over into the diabetic state. But they're also the group that's more likely to benefit from using a statin. So I think we have to recognize that when we use a drug like statins with all their benefit, there may be collateral damage, which is that some people who are going to benefit from it, we're going to be pushed over the hump into diabetes. Now, what nobody's bringing up during this whole discussion is that other drugs that we use, now with some question, also cause diabetes. For example, niacin. It's been known for years, and yet if you look back at the Coronary Drug Project, granted, an old trial, used alone reduced the risk of myocardial infarction over 5 years. But it's not the first time we've seen a drug that interacts with lipids go ahead and cause diabetes.
Well, even just this last week, the longer-term follow-up from ALLHAT, evaluating the chlorthalidone-associated incident diabetes and showing not only was there not an increment in risk, there was actually benefit of the chlorthalidone even among the patients who developed diabetes. And so,
all drugs are not equal in terms of what the clinical consequences of their diabetogenic potential is. That's what we learned from ALLHAT. The amlodipine-induced diabetes or lisinopril-induced diabetes, they had a greater risk, whereas the chlorthalidone-induced diabetes did not. Or beta blockers are diabetogenic, but they're also cardioprotective.
There's another thing that Sanjay said that I thought was really a quite useful comment, and that was about the fact that you don't have to give up on you shouldn't give up on lifestyle changes just because you're being treated with a statin. And a lot of the diabetes that we have, at least in this country, could be prevented by a walking program, some weight loss. So those sorts of things are something that physicians ought to make sure they talk to patients about when they start them on their statin as well.
Well, that's interesting. I've seen one suggestion that statins may cause diabetes by the few people, or the plurality of people who get some myalgias have a relatively reduced physical activity level, and by that mechanism there's a secondary effect. I think that's stretching it a little bit. Yeah,
we've looked at myalgia for a long period of time, and a couple of interesting comments about myalgia. One, if you look at the PRIMO study by Eric Bruckhart out of France, about 8,000 French patients treated with high-dose statins, they had about 10% of people who developed myalgia. When we take patients who I clinically think have myalgia, and I put them on placebo or simvastatin and then cross them over, it's amazing that only about a third of the people that I clinically am convinced have myalgia turn out to be able to identify, to get myalgia when they're on the statin and not get it on the placebo. So a lot of people ache, but a lot of people probably don't have statin-induced aching So, people should continue. I think it's really stretching it to think that the myalgia is so bad or so extensive that that's the cause of the diabetes, but then we don't know yet, do we?
Right. Well, let's switch gears a little bit and just talk a little bit about the cognition signal. The product label was modified as a much lower level of evidence, but some suggestion of at least temporary cognitive impairment. I know, Dr. Thompson, you've contributed to that literature. What's your opinion? Do you think that's real?
I do think that some people get cognitive impairment on statins. I think it's been anecdotally talked about for years. I've had plenty of physicians, quite reliable folks, who tell me that they have cognitive dysfunction on statins and when it's taken away. And one of the papers that was cited by the FDA, I believe, was a paper by Beth Parker, who works with me on one of the patients that we saw with this. We're presently funded by the NIH to look at 150 patients by looking at functional MRIs of the brain. Our preliminary studies, however, do show that there are changes in brain fMRI when people go on high doses of atorvastatin versus placebo. But we were unable to identify cognitive changes. So I think what we know so far is there is a possible signal with some people with cerebral function. It's probably quite rare. And it's something that patients and physicians should at least pay some attention to. We don't have definitive data at the present time. I think it's just a warning so that physicians don't dismiss these complaints from patients out of hand. And I think that's a good rule in general. Like all of my NIH grants have actually come out of some complaint that some patient made to me and that I initially didn't believe, and then looked in a little closer, and there was actually, we could document something that supported it. So I think the message is that some patients may actually have it. It's really got to. I suspect it's even much rarer than the myalgia thing, which we think is rare as well.
Yeah, and before we move on to kind of some closing comments, I think we have to also acknowledge that a third product label modification was made, and that was the withdrawal across the class of medicines for routine liver function monitoring for patients who are on statins. I think the National Lipid Association kind of led the charge about 2006 with a statin safety summary that suggested we need not be doing that. I've actually stopped doing that in my clinic long ago, but we still have lots of physicians out there routinely monitoring liver function tests. And on a case-by-case basis, it's not that much of a big deal, but on a population basis, given the penetrance of the drug class, that's a very expensive monitoring program for no reason, so we can back off. So let's just close the last few minutes here. So Sanjay, are the product label changes, and specifically for the diabetes and the cognition, are they justified?
Yeah, well, yeah. I mean, I think the FDA is caught in a tough position. They look at different sources of information and evidence, and when they feel that it rises to the level where they have to at least make the physicians and the patients aware, then they're required by law to do that update. And so it's one of those updates, what I call be aware. But at the same time, what they said about the benefits of statins are indisputable. But you got to make these decisions with care and knowledge of potential side effects. The emphasis was only on side effects. The first word that they said was that the benefits are indisputable. So they're required by law to make physicians and patients aware, and we also need to make these decisions on a case-by-case basis, addressing what the benefit-risk trade-offs are.
So I'd say the FDA reaction and the statement is appropriate. The reaction is probably not.
Yeah.
In other words, I think there's definitely been an overreaction to what is a very rare side effect problem. I think it's important that we make sure that message gets across to patients. And one of the messages I try to tell patients is that if I treat you with statins for 5 years, I think I've made your arteries younger. And I don't think there's, from any of this sort of stuff, permanent damage that's been done. So I know I've permanently improved your arteries, and I know I can stop that statin, and your aching that you've heard about from the newspaper will go away quite promptly in almost all cases. So again, the benefits clearly outweigh the risks, and the risks seem to be, in most instances, reversible. Now, I have to hold on that a little bit, because what we don't know is those people who develop diabetes, if you stop the statin, does their diabetes goes away? My guess would be that it does, because I think, if our postulate that it's related to a mitochondrial effect, that mitochondrial effect should be reversible, but until that's shown, we don't know that.
Yeah, and I think you said it perfectly well. I think the diabetes signal product label modification is justified. I think the reaction I've seen so far to it. So hopefully this panel, I think it's a consensus here, is that we acknowledge it may be real, we may even believe it's real, but it probably should have little impact on our clinical decision making. I'm not convinced the cognition label warning modification was justified based on the scant evidence we have. I think it's certainly reasonable to consider further evaluation of this, but
that may be fair, quite frankly, because it is primarily an anecdotal case report literature. Mm-hmm. So I think it's fair to some extent.
There are anecdotal reports that go back to the 90s, but then this whole issue was revisited during the FDA panel deliberation on Jupiter, where the FDA reviewers addressed these neurocognitive side effects. And then there's another source of information that the FDA utilized with the MedWatch adverse event reporting system. So it's a conglomeration of different sources of information that informs this update. I don't have any problems with that. I think when you see information from three disparate sources, I think you got to report it. But they also said that this is a non-serious adverse event, and it reverses as soon as you stop the drug. Okay,
fair enough. Any final comments?
Yeah, I tend to agree with you, Darren, in that I think it may have been a little premature with the cognitive thing. And that's just because people react to that so strongly. Quite frankly, I got more patient reaction to the cognitive thing than I got to the diabetes thing. Mm-hmm. So I wonder, I'm not certain, but your comment that it may have been a little premature, you know more about what, I guess, some data that's not been revealed to us, Sanjay.
Right.
But, so I think I'm a little ambivalent about whether that should have come out so early.
Okay, well, thanks, guys. This has been interesting. It'll be interesting to see how this plays out. So, Sanjay, Dr. Thompson, thank you, and thank you for watching.